So this is basically one of our first recording of the Spine Bros. I'm Dr. William Sonstein of NSPC Brain and Spine Surgery.
And I'm Rich Obedian of Island Spine and Sports.
How did I meet you?
Well, we kind of met through Dr. Michael Brisman, who's the...
Dr. Brisman's my partner.
Right. So Dr. Brisman and I have a long history. We were friends as children. We went to the same synagogue growing up, and we were in the same bar mitzvah class. And Michael was very smart, and he ended up going to Harvard University for college, and I went to University of Michigan. But then we met up again during medical school. We both went to Columbia. And he was randomly assigned to be my big brother during medical school. So we were friendly during medical school. And then once again, life took a different path, and he went on to a neurosurgery residency at Mount Sinai. I did general orthopedics at the Hospital for Joint Diseases. And we kind of lost touch with each other throughout our residency, but then we met up again in the halls of Winthrop, which is now owned by NYU. And I said to Michael, we should do a case together.
Started getting talking.
And we did a case. We did an ACDF. We did a neck fusion. And after the case,
how did it go?
It went phenomenally well. That was before I knew you. But we got along very well.
You could have stayed with him.
Well, he recommended that I do more complex cases with the spine guy in the group, who happened to be the young Dr. Sonstein.
So I joined with Dr. Brisman 26 years ago.
You started at the same time.
His father was a neurosurgeon, and he wanted to follow in his footsteps.
Ron Brisman.
I had no doctors in my family, so I basically was the first pioneering, basically surgeon and doctor. So I joined with him, and I had done a spine fellowship, and I wanted to do spine cases. And I was always told by my other partner who joined subsequently, who was my attending in Montefiore, where I trained in residency, he told me, don't be enemies with the orthopedic surgeons. They'll always beat you at your game. So I said, what does that mean? He says, well, they have a lot of patients to be seen, and maybe you can work with them, and maybe you'll have more fun and basically better experience. So Dr. Brisman introduced me to you.
You're right. It's better to collaborate with two different specialties. We're trained differently. We're trained more from an orthopedic point of view.
You guys are basically taught how to connect two bones together. Your whole residency.
We're the fusion specialists.
Right, you're fusion specialists.
And we're a specialist in metal, putting in hardware and screws. We're more like the carpenters.
And we're basically like the electricians. So
yes.
we love to work around the nerves. We're not afraid of the nerves. Like the orthopedic surgeons tend to be kind of afraid of the nerves.
Well, we're more afraid of the spinal cord, things that are, we're afraid of the dura.
Yeah.
Spinal fluid leaks.
Yeah.
As anybody,
we're there to help.
As any spine surgeon should be afraid of that.
And we're always there to jump in and save the day, with
Not that we're really afraid. We're just concerned. And it's nice to have another pair of hands. When you're training as a resident or as a fellow, you have multiple other surgeons that you can confer with as you're doing the operation. And you always like to get their opinion. Did I decompress enough? Did I go out far enough laterally? Did I destabilize the joint? What should we do next? And having another fellowship-trained spine surgeon in the operating room is invaluable. Much more valuable than having a PA, like some surgeons use, or a physician assistant, or a nurse practitioner, or even just another orthopedic surgeon who is not spine trained.
Right.
Who's not spine trained. Like, for example, when I first started, I was doing spinal surgery with a hand surgeon. And I was horrified with the first operation. He shows up wearing loops, and he really had no idea what he was doing around the spine tissues. He was a little rough, and it was a problem. And we did get a spinal fluid leak. So it's.
How did you fix it? Did you call a neurosurgeon?
We did it the old-fashioned way. We did it ourselves. But it's much more pleasant. It's much more calming, to have another fellowship-trained spine surgeon. And when you go into the operating room, you really want to be confident. You don't want to have a surgeon who is nervous. If your surgeon's nervous, you should definitely run away. You want a surgeon who's going to be focused on you and not be concerned, not be worried, and you don't want it to be his first rodeo.
You want somebody who's going to
somebody who's got experience.
You want to anticipate your moves, my moves.
Absolutely.
And basically that's really the point of this whole thing, is that both of us are in private practice, and we essentially work attending together, not using anybody else but ourselves in the operating room. And that's what we offer our patients. So we've been working together for
over 20 years,
about 23 years already at this point.
That's right.
Remember the first time we wanted to work together?
Yep, we did a case at Plainview Hospital. It went extremely well, and ever since then, it's been like I discovered my brother from another mother. Hence the name, the Spine Bros.
So we basically do everything together. We're like a team. We basically, every patient that we see, we run the patient by both of us. This patient sees both of us, and the patient gets our opinion. And I think that's really a fantastic thing for the patient to be able to get.
Absolutely.
Because, for us to take a patient to the operating room, we both have to sort of agree on the plan.
100%. And it's very helpful to have another spine-trained specialist give you their input as to what they would do, what they think the pain generator is. They've examined the patient, and I find that Dr. Sonstein's help is invaluable, both in the office and in the operating room as well. I trust his judgment. I trust his clinical skills, his surgical skills. It's really a partnership that I treasure.
Well, I agree with you, and I feel the same way, which is very nice. So we do a lot of degenerative stuff that basically is sort of the bread and butter, the most common types of problems we see. We see problems in the neck, cervical spine, lumbar spine, degenerative conditions, mainly conditions where the nerves are being pressed upon or the spinal cord is being pressed upon, and we specialize. I think, what we've developed over the years is really a specialty practice that where we are able to decompress patients with difficult cases.
Right. Everything from a herniated disc in the neck to the thoracic spine to the lumbar spine to narrowing of the spinal canal, which is also called stenosis. There are conditions like spondylolisthesis that can also cause narrowing of the spinal canal. And sometimes, in addition to decompressing them, they need to be fused as well. And we handle all of these problems.
I think we're very conservative in our use of fusion, actually. That's one of the things people are most scared about. It's funny because the real main event of the surgery in most cases is the decompression. That's the hardest and trickiest part. The fusion's actually kind of the more straightforward and the easier part of the surgery.
I agree.
And it's funny how people, sort of focus more on that part than actually the thing that's really most important, which is relieving the stenosis, which is really the most skillful aspect of the surgery. So one thing we do, we're not liberal in our use of instrumentation, for instance. We like to try to see if we can get away with fusing sometimes people with just bone graft material and not use screws. But when we need to use screws, we use screws. And in the neck, we use plates and we use basically cages. And we are definitely interested in those types of cases.
Yeah. Do you want to talk about the first case, this herniated disc of the cervical spine?
Yes, we've done a lot of interesting cases lately. We both came back from vacation. We're well rested, and we came back with a flurry of really interesting cases. Dr. Obedian here had just gotten back from a whirlwind trip on a cruise, and I as well. And I was basically interested in getting back into the swing of things. And basically the next day after coming back and being jet lagged, we had basically two interesting cases. We did.
Well, I felt fine.
You felt fine.
I felt fine.
But you were coming from the other.
I was coming from Italy, and you were coming from Alaska, so a little different.
Alaska's pretty beautiful.
Yeah.
So I contemplated a lot of what I do during my trip, and then it's good to sort of absolutely get back into the swing of things after you've been sort of just doing not too much other than just sort of looking at beautiful scenery.
We were fresh and eager to go. And we started with a really nice case of a young woman with who actually had a herniated disc in her cervical spine that was causing severe arm pain. And the interesting thing about her was that she had a C5, originally I believe she had a C, correct me if I'm wrong, but I think she had a C5, C6 disc.
She had a big C5, C6 disc that was sort of centrally oriented, and it was off more to the left side. But the funny thing is,
she had more right arm pain.
She presented with right arm pain, which
that's right.
So that's really one of the main things is that if a patient presents with a symptom and sign that is contrary to what's the finding on the MRI, one should not be so, first of all, apt to want to recommend surgery, but to really kind of investigate why that is.
Right. The art of choosing a patient for surgery is trying to figure out what the pain generator is, and are you going to be able to help them? And so, and not just pain, but also numbness, tingling, and weakness. Is that definitely coming from the spine, or are there other causes of it? And not to be cavalier, but we don't run to a spine operation initially.
No, we
There are many
definitely
other
try to
things that we
exhaust
try. We exhaust all non-operative treatment first.
physical therapy.
Sometimes a chiropractor. How do you feel about chiropractors?
Love chiropractors. They really know a lot about spine, and that's what they really focus on studying. And so when you speak to chiropractors about spine problems, they actually know what they're speaking about.
Yeah, they're surprisingly very knowledgeable.
They see a lot of patients, so they're good referrals for us, and we interact with them quite a bit.
It's like every other field. There are good and bad, but I think in the New York area, at least on Long Island, we've really encountered some excellent chiropractors out here.
I think so. And we also have some excellent pain management specialists that we also send patients to.
Right. And so the pain specialists can do things like epidural steroid injections,
trigger point injections,
radiofrequency ablation. They have a multitude of different interventions that they can try that are short of an operation.
I think that patients, when they have severe pain down in a leg or arm, those patients are very amenable to an epidural injection if they fail physical therapy. It's the patients that worry me are the ones who have spinal cord compression. Those people from arthritis or from a herniated disc, those people I'm not so apt to want to send to pain management because they have spinal cord symptoms, which I think are more serious.
I agree 100%. You got to be careful who you send because these spinal interventions are not benign either. And there's now a trend for some pain specialists to be doing isolated discectomies without doing fusions in the cervical spine, which is, I think, a little controversial, and I think it's a little bit of a problem.
Right. So, I think that for that kind of thing, I think it's best to refer the patient to people who actually do the real discectomy and fusion, and not necessarily patients trying to avoid, what is inevitable, what they need to have done, what's the right thing for them to have done to get the problem taken care of for a cure.
Right. So what are your indications for doing a spinal surgery on a herniated disc in the cervical spine?
So patients generally, I'd say 90% of people who have herniated discs that are causing compression of a nerve, not the spinal cord, they get better. And with
they don't need an operation.
They don't need an operation. They get better with time. Time is probably the best modality of treatment. And they get better with anti-inflammatories. Epidural injections we'll send them for if they have unrelenting pain. And then if they respond to physical therapy, we don't need to do much more than that. But sometimes these people have unrelenting pain, and sometimes people have weakness they develop, and they fail those types of treatments, and they have an MRI that correlates with their symptoms, and they have basically given it a real go-ahead of conservative management. Those people, I think, are the best candidates for surgery.
Yeah. Voltaire, who's a doctor from the 1700s from France, once said the doctor's job is to entertain the patient while nature takes its course.
That's right.
So as but sometimes, as you said, no matter what you do, these patients remain symptomatic despite all your best efforts to get them better, whether it's physical therapy, chiropractic care, interventional pain management, and really more than anything else, probably time is what's going to heal them because people have been getting herniated discs for thousands of years. We've only been diagnosing them for the last 100 years with the new imaging technologies. But now you've got this patient who's not getting better, who's got numbness and weakness.
And she had pain on the opposite arm. So
you maybe get a new imaging study, huh?
So that's the thing. Discs can either basically sometimes progress or they sometimes can regress. They can go away, actually, with time, which is interesting. We've had cases where we've had a patient who had an MRI which showed a herniated disc. We go in to operate, and the disc is practically gone.
Yeah.
After a period of time. So it's always good to have an up-to-date MRI when we're basically trying to decide on a surgery on a
Absolutely,
patient.
that's very important.
So we did, and this patient had conservative management. She had physical therapy. She had steroids, which are anti-inflammatories, which were given to her, and she had epidural injections. She got no better. I thought maybe perhaps the fact that the disc was central and was causing some spinal cord impingement, maybe that was causing some sort of contralateral pain. So we got an MRI, and that was very interesting because the new MRI showed that not only did the C5-6 disc, which was the initial disc, regress, but she developed a new C6-7 disc off to the right. And that explained her symptoms of her right arm
persistent pain,
and pain. So that made sense. So we decided when we saw this patient to perform
do both levels
because she still had some residual C5-6, and she had C6-7 as their main problem, causing compression mainly of the right, what we call C7 nerve root, which is often goes to the triceps and the muscles that move your fingers upward, finger extensor muscles. So she had that weakness, and we decided to take her to the operating room, and we did a 2-level anterior cervical discectomy.
Right. So what are your surgical options?
So we have a lot of different options when a patient has that kind of thing, but most of the time we standardly go from the front. We make a very small incision in the front of the neck where we localize where that incision should be based on where we have to go in the neck.
So you take a preoperative x-ray in the operating room.
We take
to kind of determine where the incision should be.
We take an x-ray. So we know where we're going to be, because you don't want to make an incision and not in the right spot, because you don't want to have to stretch the actual exposure up to try to because you don't want to compromise visualization. That's the most important thing.
You don't want to struggle.
You don't want to struggle.
You don't want to have to pull on the soft tissue to get to your level, because really to do a 5 to 7 ACDF, you got to expose a C5 vertebral body, the 5-6 disc space, the 6 vertebral body, the 6-7 disc, the 7 vertebral body. So you need a lot of room. And so if your incision is too high, you're going to really struggle to be able to expose it, and you might have to extend your incision and make it bigger.
Right, which you don't want to do in and this woman was actually a young woman. I believe she was 26 years old.
Yes.
She was a nurse. You just wanted to do an excellent job on her.
And you want it to look cosmetic at the end of the day as well, because that's something people are going to notice.
We always like to use plastic surgeons to close that's one thing we offer our patients, is we have a plastic surgeon who's been working with us for 15 years.
Yeah.
Who does an outstanding job of closing the wounds.
It's really a game changer, both in the neck and also in the lower back and the posterior cervical. When you go from the back of the neck, it really helps us tremendously. They are experts at managing the soft tissues. Our infection rate, thank God, is extremely low. We should knock on wood.
Thank you,
Spike. And but so how about you hear a lot about disc replacement. Is there an indication for a disc replacement in somebody who's that young?
Well, it is controversial. There really hasn't been any studies that have proven that there's a better outcome with a disc replacement.
It's equal.
And also for basically doing a disc replacement, it's controversial whether to do, if in a case of this, to do 2 levels for a disc replacement. So in my opinion, I thought the best approach for her, and I think we both agreed, would be to do a fusion in addition. And the reason why you do a fusion is to prevent deformity, number one, and also to prevent the disc from coming back, or at least have any other development of arthritis.
How about just doing a discectomy and not doing the fusion?
Well, in the old days, people used to do that. They
failed. They
failed, and they got deformities as well. So in this case, we removed the disc, the whole disc actually, and we decompress the spinal cord and the nerve canals on either side. And one thing we wanted to make sure of in this patient, because she had a C6-7 disc that was actually causing compression, was we wanted to make sure we found the fragment.
Yes.
And we did.
Yeah, it was.
And
really
I thought
fun.
that was really great, because it was tricky in that case, because it kind of went upward, if I recall.
Yes.
And we had to sort of fish it out.
Yes.
But when we fished it out, we were very happy. We were always very excited.
Very excited. It was...
When we take out a disc, we always hold it up for everyone to see and rejoice, basically, every time we take out the disc. Because we know
it's a hallelujah moment.
And it's a great thing, because we know that
Praise the Lord.
Likely going to make the patient a lot better, and we're going to feel good about that.
We know we found the pain generator.
We found the pain generator. So we did that on her. We did the case, and
then you secured the fusion with you had bone graft or a cage. And
I think in her we used actually 2 cages, which is something we've been doing more lately, because the device that we're using is very slick. It's very nice because it's got sort of a plate attached to it, so we can actually not have to fiddle with putting the plate on, and the plate is already there in perfect position, and we just put the screws in. Yes. And we basically secured it.
And that's made of titanium, the plate in the cage.
It's made of titanium, so they can get post-op MRIs without too much distortion.
Right. Well, that's another problem in doing a disc replacement, is that a lot of the disc replacements are made of stainless steel, cobalt, chrome, which are not MRI compatible.
Right.
And somebody who you're worried about getting repeat image, especially a younger person who might go on to develop other problems in the future, imaging can become a problem, because the cobalt chrome interferes with getting an MRI. And then you've got to get a CT myelogram, which is an invasive procedure. And MRI is really the gold standard test.
Right.
So especially in somebody young, you want to veer toward maybe not doing a cobalt chrome type of a disc replacement. Although I think some of the newer disc replacements are now made of titanium as well.
So we'll have to see what happens over time. And as technology evolves, we evolve. You know, we basically get involved more with what we've seen for a while. We don't try to get in on technology when it just comes out. We try to see how things go for a while.
Right. You know, when I was a fellow, Dr. O'Leary, who was my what's the
preceptor?
Word? My preceptor.
Patrick O'Leary?
Patrick O'Leary from HSS.
The Patrick O'Leary.
The famous Patrick O'Leary.
Yes.
He advised me, you don't want to be the first person on the block doing new technology, because invariably in spine, a lot of these new technologies tend to fail, and you don't want to be associated with a failure. So the advantage of using Dr. Sonstein and myself is that we've been doing this for over 20 years. We're at the peak of our game. We know what we're doing. We have experience. And, you know, you want that in the operating room, somebody who's not green, somebody who's not brand new, somebody who's seen multiple different types of problems. It's not their first time they're seeing something, and they have the experience and the knowledge and the expertise to be able to fix your problem.
Well, who love doing this. I mean, I would, oftentimes I would prefer to wake up and go into the operating room with Dr. Obedian than to hang out at home.
Oh, absolutely. I mean, remember during COVID, the operating rooms were all shut down, unfortunately, because of the pandemic, and we just couldn't wait to get back.
Going crazy.
Yeah, it was really a depressing time for us for a number of reasons, but one of them was that we weren't able to operate.
We weren't able to do elective cases.
The ORs were all shut down because of COVID. They were using all the ventilators, so that was a dark time in medicine.
Yeah, that was definitely a very difficult time for us.
Yeah, but thank God we survived. We're stronger than before, and the good news is that this particular patient did extremely well. And when she woke up in the recovery room, she already noticed a dramatic improvement in both her pain and her weakness.
And the reason why, I think, is because particularly the C6-11 level, the nerve is very resilient at that level.
Yeah, much more resilient than the C6 nerve.
Right, exactly.
I would say, or C5 nerve.
And especially the distal one, too, the C7-T1. Those people with hand weakness, because they get a C8 distribution, which is more of the distal fingers, and those people can basically be up to 2 years to see improvement, actually.
Yeah, it can take a long time. Also in the lumbar spine, it can take a while for the nerves to recover. But, yeah, thank God I saw her in the office recently. X-rays look perfect. We can probably hang them up later on.
They look beautiful.
They look beautiful, and she's doing beautifully. She's going to be returning to work soon, and she's very grateful that her arm pain is dramatically better. You know, one thing she said to me is, if I had known it was going to be so easy, I would have done this a lot sooner. You know, which is a very common thing that patients will tell me after ACDF surgery, after next fusion surgery, because they hear so many bad things about fusions and about cervical spine surgery. You're going to be on their spinal cord. They're understandably very nervous, very scared, and they need to be reassured.
One of the things that we do in the operating room, which is pretty standard, is we monitor the patients. We have a whole electrophysiology team that monitors the nerve impulses as we're doing the surgery to make sure what we're doing is safe.
Not only what we're doing, but also how we position the patient. Because when we put the patient on the operating room table, they're asleep, and we tilt their head back a little bit, and they can't tell us, oh, my arm just went numb when you did something. But the monitoring people will tell us with the positioning, how we're doing, make sure there's no impingement on any nerve, there's no problem. And it's not just the spinal nerves, but sometimes even their peripheral nerves, ulnar nerve, for example, in the upper
around the elbows. And
around the elbows, those can get pinched off also just from the positioning.
So that's really
So we take every precaution to make sure we give the patients antibiotics before, during, and after the operation, and we often put a drain in as well. I would say virtually every ACDF we
always put a drain, and we always keep the people overnight to make sure they're okay, because it's the neck and it's near the windpipe, and it's near all the important structures. And if a person somehow develops any bleeding, at least they're in the hospital, not at home, that it can be addressed.
Yeah, you want to be able to get to that very quickly. Fortunately,
it's exceedingly rare, thank God, but still, it's always good to make sure the patient's okay overnight.
My feeling is it's always better to be cautious.
Absolutely.
And have a 23-hour stay. At least you get to see them the next day, see how they're doing, make sure they're speaking okay, they're swallowing okay.
That's the one thing that patients have difficulty sometimes if in that kind of surgery, is they can get swallowing difficulties.
They can get speaking difficulties if you injure the recurrent laryngeal nerve,
Happens in 1% of the time, which is pretty rare.
Pretty rare. What do you do if that happens?
We have a cure. The ear, nose, and throat doctor comes and actually can inject Teflon and actually move the vocal cord over, so they basically
regain their voice,
cure their voice and their swallowing.
And if they don't do that, they don't lose their voice completely. They just have a hoarse voice.
They have a hoarse voice, but they can have trouble swallowing. They can aspirate their food, so it's not a good thing. So you want to try to be as gentle as possible when you retract in the operating room, and hopefully, with luck, you don't ever get a recurrent laryngeal nerve.
There are some tricks that we do during the surgery to minimize damage to the recurrent laryngeal nerve as well.
That's right. We ask the anesthesiologist to basically deflate the endotracheal tube.
The breathing tube.
Yep, that's one thing. Intermittently to try to help relax the pressure or give less pressure on that nerve, which runs between the trachea and the esophagus.
And when I do the retraction, doing it very gently to minimize any trauma to the esophagus and the trachea as well, so that there is no trouble swallowing afterwards or a tear of the esophagus.
The good thing also about the doing it at what we call an anterior from the front is that the incision doesn't hurt very much. Now, this is in comparison to patients who have operations from the back of the neck, and also patients who have low back surgery, for instance.
There's a lot more muscle in the back of the neck and the lower back. And that's what's caused the pain. Is that exposure?
Very little muscle in the front. So
thin little muscle called what does the platysma do?
Basically, the platysma muscle actually allows you to move your head forward.
The peacock.
Exactly, the peacock.
Yes.
That's what that does. So that's really the only muscle, and maybe what we call a strap muscle, which is just an accessory muscle we need to sometimes divide. But other than that, patients actually don't complain of much pain from that type of surgery. So that was a very I think straightforward operation we did. It was an interesting presentation though. So the take-home message from that whole case is that you got to be sure that what you're doing is correlating with the MRI, and we proved it by repeating the MRI. And if you have to repeat the MRI, you have to repeat the MRI to make sure that you're doing the right thing.
Right, absolutely. I mean, the MRI is like a roadmap. And if you think of an operation as a battle, you want to have the best espionage, the best imaging possible, so you know where your enemy is. And the enemy in this case is that herniated disc. So, and like Dr. Sonstein said earlier, discs can shrink at one level, they can get bigger at another level, and you don't want to have any surprises when you go in.
Oftentimes, it depends on the state of hydration of the disc. The discs sometimes, like any other thing, if it's filled with water, the water gets reabsorbed by the body. So if it's more hydrated, the disc itself, then it can actually have a higher chance of having reabsorption.
Right. So sometimes the pain's coming from actual mechanical pressure from that herniated disc pressing on the nerve. Sometimes it's coming from chemical irritation from your body trying to eliminate that herniated disc. That's why anti-inflammatories and steroids will often work. But, thank God in this case, everything went smoothly. The patient had an excellent outcome, and she's doing quite well. We can report that for sure.
Some discs we call hard and some discs we call soft. In this patient, she had something called a soft disc, which was more the jelly part of the disc. The disc is like a jelly donut, and the jelly came out. Where some patients, we call it a herniated disc, but really what it is, it's a
calcification.
It's a calcified area.
It's more of a calcified annulus. It's the outer portion of the disc.
It's like bone that's jutting into the nerve or the spinal cord.
It's an osteophyte.
That's called an osteophyte, right? Yeah. We have to drill that down sometimes to a fine shell and remove it with our fine tools.
Right. An osteophyte is just a medical word for a bone spur. And bone spurs develop when there's instability in the neck or in the lower back.
That's another argument for fusion because these people
stops the motion.
So the arthritis is simply the body's response to instability. So the body makes these things
to try to fuse itself.
And the spine doesn't care. It has to take care of itself and stabilize itself, and the nerves become collateral damage.
That's right. That's exactly what happens.
So that's why people basically develop these very, very severe compression areas because they're unstable.
Well, it's like the arthritis that develops in the knee or the shoulder or hip. The problem is that in the spine, when the bone spurs develop, or these osteophytes, they'll press on nerves.
That's right. And basically the spine is just a series of joints stacked on top of each other.
That's exactly right.
And they're like any other joint in the body.
We're going to teach you orthopedic spine, bro.
Well, look, spine bro, I've been thinking about orthopedics for a long time. In fact, in my fellowship, we had a very prominent orthopedic spine surgeon there teaching us a lot. So
Dr. Rectine.
Dr. Glenn Rectine, who was very conservative.
Is he still in Tampa?
No, I think he went down to Texas.
To Texas. All right, good for him.
But in any event, I really, always learned, and also my mentor in fellowship also learned a lot of his spine knowledge when he trained from the orthopedic surgeons. Orthopedic surgeons were the first ones to really put instrumentation and fusions and do that kind of stuff. We kind of jumped on the bandwagon in the 90s.
It's interesting. We talked about putting plates in the cervical spine for fusions, and that really started in the 80s and 90s. And the first generation plates that they were using were orthopedic surgeons were fixing ankle fractures at that time. And they were using something called the 1/3 tubular plate, which is a very thin stainless steel plate to fix an ankle fracture. And they said, well, if it can fix an ankle fracture, it should work in the spine as well. Problem was that it wasn't very strong, and it tended to bend, twist, and break. And so now there are much better plates that we use that are designed specifically for the cervical spine.
That's right.
And they're called third generation plates, which are made of titanium, and they're really almost destruction proof. I've seen patients who've had car accidents after cervical spine surgery fusions, and their plates remain intact. It's very hard to break those things.
I've
never seen it.
I've never seen a plate actually break. A screw can sometimes loosen, but
I've seen screws loosen, but I haven't seen a plate actually break.
Are pretty strong.
Yeah, and they've got to be strong because your neck goes through multiple types of different motion, both flexion and extension, rotation, twisting side to side. So there's a lot of different motion that plate has to be able to withstand. And those plates are really quite excellent.
Also, I've noticed sometimes disc replacements, patients who come in who had them, sometimes they'll actually end up fusing across their actual space where they actually had.
Yeah, there have been some studies that have shown that the disc replacement patients, some of them do go on to fuse, and that may be why their results are the same as
I've had
fusions.
Patients who have had fusions from their disc replacement and actually develop a disc above the actual or below the actual fusion of the disc replacement, which is what it's supposed to eliminate the possibility in the first place.
I think the future for disc replacements is probably good. I think there's a role for them, and we'll have to see how they do over time. But I think it's a good thing to be able to offer to the right patient.
Absolutely, and the technology is getting better and better.
As the technology gets better, maybe it's something we could start doing as well.
Absolutely. So there was another patient we had done that day actually after that. A young lady we
did an older lady with a posterior cervical.
She had spinal stenosis, severe spinal stenosis,
multiple levels
of the cervical spine.
I think she went from C3 to C6 with a severe spinal stenosis.
She had a kind of a strange curve to her spine.
Right, she was kyphotic. So there's two types of curves to the neck.
She's kyphotic.
The normal curve is lordosis, which is a C-shaped,
more forward bending.
Right. And then the kyphotic one is when you're bent leaning forward instead of leaning backward.
Which is basically the opposite of an ideal situation to do a procedure from behind in the cervical
Generally,
spine.
when there's kyphosis, you want to go from the front.
Right. And this lady actually had an interesting cervical spine because she had more of a kyphosis at the top of her neck, but started to actually become more lordotic where she had the stenosis. So we felt in this lady who had severe cervical myelopathy or signs of spinal cord.
What's myelopathy?
Myelopathy is a fancy word that means spinal cord signs, which means that they oftentimes have problems moving their arms, their hands. They have numbness. They can have difficulty using their legs because the nerves that control the legs have to go through the cervical spine first.
They have an unsteady gait. They have trouble with fine hand coordination.
They have difficulty using their fingers and buttoning shirts.
What's interesting is that it's very common in the Far East in Japan. And when I was a resident, I did a paper on cervical myelopathy. And the scoring system at that time was the Japanese Orthopedic Association. And one of the criteria for sign of myelopathy is inability to use chopsticks.
There you go.
So in Japan, if you can't use chopsticks, you're going to starve. It's not a good thing.
You better get an MRI.
You better figure out what the hell's going on in my hands that I can't use them, and I can't eat the sushi.
Well, that's a good way of telling. So I should give out patients, some chopsticks and say, hey, can you use them?
You can ask them. Do you have trouble using chopsticks? Interestingly, I had a few Asian patients who were having trouble with chopsticks, and they were indeed myelopathic. So it's a good thing to ask.
I usually ask people, do you have trouble, buttoning a shirt or something like that, or opening up a jar, things like that. It's everyday tasks.
They're normal everyday activities. They're ADLs.
So they get compression of their spinal cord, and oftentimes you'll get an MRI. It'll show changes within the substance of the spinal cord, sort of a scarring.
Like an edema in the spinal cord.
Which shows you that they've been pushing against their spinal cord for a long time, usually due to arthritis. Sometimes it's a herniated disc. Sometimes it's due to just chunks of arthritis that form. And sometimes it comes from the front. Sometimes it comes from the back. Or sometimes it comes from the front and the back. And this patient, she had both front and back compression of her spinal cord.
Right. And sometimes when you have patients like that, you've got to approach them from the front and the back. I find that you're better off going posteriorly first and seeing if that solves their problem, and then they can avoid doing an anterior operation.
If they have a reasonable curvature, like a reasonable lordosis, in my experience, I think what we have found is that what happens is that when you approach removing the pressure from behind, the spinal cord will move away from the front of the spine. When they have a good lordosis. If they have a kyphosis, they have essentially a V pressing into their spinal cord, and you won't relieve it well by doing a posterior, what we call posterior removal of pressure.
Well, there's a bowstring effect, so you got to really decompress maybe a little higher and a little lower to adequately decompress them and give the spine room to breathe.
But ideally, you want a reasonable curvature, at least a straight to a reasonable lordosis to do a posterior or behind approach. The spinal cord is surrounded by a bony ring. And if you relieve one side of that ring, you are essentially relieving the pressure in the spinal cord.
So you like to go from the back if there's multiple levels, so you can avoid all those problems we talked about before, as far as difficulty with speaking, difficulty with chance of a recurrent laryngeal nerve injury, or difficulty with voice hoarseness, dysphagia, which is trouble swallowing.
I like to avoid those things because in an older person, like in this case, they can be much more difficult to basically handle. The younger woman, all her problems from the front, and it was most easily approached that way. And a posterior or behind approach would not have been appropriate in her case, especially a younger person. In her case, the older lady that we did, this was appropriate because of multiple levels. The more levels you do from an anterior approach, the more risk you do have of swallowing difficulties. Going from behind, you just have muscle. You really have no vital structures in where you have to approach a posterior cervical decompression or posterior cervical, we call laminectomy. So that's why we elected to go posteriorly in this lady.
So when you do a laminectomy, especially in somebody who's a little kyphotic, you can make their kyphosis worse unless you add the fusion, correct?
That's correct, because you want to make sure that they don't develop a deformity of their neck or a swan neck in the future.
So then you fuse them but you don't use a plate in the back of the cervical spine. Instead, you use lateral mass screws and rods.
You use little tiny pins that go into the little joints on the side. There are joints on either side of the cervical spine, and those joints, those processes, actually have enough bone in them for us to put a screw in that gets good purchase, and it allows us to keep the patient's alignment after we've done, we call laminectomy, or decompression or removal of pressure on the spinal cord.
Now, when you do a fusion, it's not just the screws and the hardware that you're using.
No.
You're using bone graft as well?
The bone graft is actually the most important aspect, because the screws give you the initial stability, but what you want over time to happen is the bone to actually meld together between the levels so that provides the strongest strength for that patient.
And if the patients go on not to fuse, that's when you get problems with the hardware where it becomes loose.
Hardware can become loose. So you hope that you set up an environment to basically have the best chance for fusion, which means that when you do a fusion, you have to make sure all the soft tissue is removed from the bone to create an environment that's best for fusion.
And oftentimes before we put screws in both the lower back and the neck, we'll do a test called the bone density test to see the quality of their bone and how likely it is that they're going to be able to hold the screw and get good purchase. You know, like we said before, I'm like the carpenter, so I'm making sure that those screws get a good purchase, that they're not going to become loose right away. Sometimes we put a screw in and it's very loose. We're not going to leave that screw in. We have other options such as using a larger screw. Sometimes we put cement with that screw to make sure that it gets good fixation.
Or sometimes we just don't.
Or sometimes we don't even put a screw in that level.
We just put down bone graft material.
You don't have to put a screw in every level.
Because, you know, really, I mean, before this instrumentation came about, people were just putting down bone graft material,
right.
which is perfectly acceptable for a fusion.
Yes, 100%.
But now that they have the instrumentation available, patients can be mobilized much quicker now because they have that initial strength of the hardware holding them in place.
And then do you put them in a collar after the operation?
Usually we put them in collars to
usually more for comfort now.
Yes, because the instrumentation, they really don't need the collar. They're not going to fall apart without their collar.
It's a reminder.
It's actually to remind other people to avoid those patients on the street.
Right, especially in the anterior approach where the patients recover so quickly, and they almost need to be reminded because they're back to their old selves within a few weeks.
I mean, unless you're really worried about the hardware or the stability, then you keep them in a collar for a while. But for the most part, patients can take off their collar when they're sleeping, when they're in bed, when they're sitting and relaxing. It's just that when they're up and about that they really probably should wear their collar, at least for the first 6 weeks or so after these types of surgeries.
Yeah, I agree. I think even a soft collar would suffice in most cases for the anterior approaches. And for the posterior ones, whether you have multiple levels, I'm more likely to use something called an Aspen collar. The interesting thing about collars is that the names of the collars come from the cities where they were invented. So the standard collar is the Philadelphia collar, where you where you grew up, where you went to medical school.
Went to Temple.
And that's a very uncomfortable collar. A lot of the emergency rooms will slap that collar on anybody who has a car accident and has a neck injury, but it's not very comfortable, and it can lead to sores of the skin. So there's also a Miami J collar from Miami, obviously.
The problem with the Miami J collar is none of the patients can figure out how to put it on themselves.
It's a little more complicated. It requires a higher IQ. And then there's the Aspen collar, which is my favorite collar. It's a simpler collar. It has good cushioning for the soft tissues. It's comfortable and it's adjustable in terms of giving you a little more lordosis.
That's right.
And give a little traction. Yeah, got a little wheel in the front that you can just dial up the amount of elevation you get of the cervical spine. So it's a really helpful, nice collar to use.
So in this patient we operated on, we were very concerned about the degree of spinal cord compression that she had. So our technique is when we go in, we expose the spine, and then we use various instruments in order to decompress the actual spinal cord. How that's done is we have to remove what we call the lamina and the spinous processes, which are the bones in the back.
That's what you feel in the back of the neck.
In order to basically get rid of the pressure. So when we work in conjunction with each other, we're always essentially, first of all, very careful how much downward pressure you're putting on when you use these instruments to bite away the bone, essentially.
You get a spinal cord injury if you punch.
You can get a spinal cord injury. That's why it's very important to keep the patient monitored during these surgeries. And we work together. We anticipate when we remove the bone, we want to make sure as we remove the bone doesn't torque into the spinal cord. So the other person is preventing that from happening by giving counter torque.
It's really a two-man job doing a decompression.
It's a two-man job, and you got to it's best. That's why it's best to work with somebody for a long time, because you anticipate each other's moves, and we don't even have to speak to each other during the operation.
We're like an old married couple.
We just know what we need to do exactly. And what we do is, one thing we always do is we check: is it okay what I'm doing? Am I okay? Is it okay? And that's always the most important thing, is communication. Because
you also have a different pair of eyes seeing it from a different angle. And sometimes I can see when if you're pulling on dura and risking a spinal fluid leak, and you can't see that from your angle. And so I think it's much safer to have two sets of eyes looking at the problem as you're decompressing.
Absolutely.
And watching every step.
And we have to make sure that what we're doing is safe. That's the name of the game.
And sometimes I'll see an area where I see some compression that's hard to see from your point of view. and vice versa. You'll do the same thing for me when I'm decompressing as well.
That's right. So that's
how
we accomplish it.
It's a team effort, and that leads to successful outcomes for these patients.
It's very important to, when we decompress these, not to essentially shortchange the actual decompression. We like to go well above to normal, to well below normal, to prevent that bowstring effect and to make sure that that patient has a nice, long, wide decompression of the spinal cord out to the curvature of the spinal cord. And that's the key.
And as you always point out to me, you don't have to remove every single morsel.
You don't.
Nothing. Sometimes there's a piece of ligament that may be unsightly, but it's not really causing any compression. And by removing it, you risk causing damage.
That's right.
So oftentimes we'll leave a fragment of some ligament which is not causing any compression.
Especially if it's attached to the dura. You don't want to risk
Absolutely.
pulling on that
and injuring a nerve or
getting
the
a leak
dura,
of
getting a
the
spinal
membrane.
fluid leak. That would be bad.
So that's what we try to avoid. So you have to, that takes time to know, or with experience, to know what you can and can't get away with when you're decompressing somebody.
That goes into the judgment.
That's
have you done enough? Are you doing the right thing? And when should you stop?
And how much pressure can you put on the nerve? How much pressure are you supposed to do? And that's really the key to spine surgery. It's sort of a controlled kind of almost aggression, where you want to remove everything is compressing, but you want to do it in a way that requires a touch.
You want to be smart about it.
A light touch, and not to actually put any untoward compression or downward pressure on the spinal cord as you're doing your decompression.
Yeah, and that's the art of spinal surgery, and that comes with experience.
That's right.
Just like selecting the right patient comes with experience, doing the right preoperative care comes with experience, knowing when to recommend an operation. That's all experience, and that comes from years of training, and it's invaluable, the experience that you've had and the amount of cases you've done. How many cases would you say? How many posterior cervicals have you done over your career?
It's probably
the thousands.
I'd say it's probably up there. It's probably somewhere around 500 to 1,000. I've never really counted how many posterior cervicals in terms of spine cases, but we definitely have done thousands of spine cases together. And
well, I would say ACDFs are probably more common operations.
It's probably more common, but as the population ages now, we're seeing a lot more patients coming in.
That's true.
Even in their 80s now, they're demanding, hey, I want to go back to doing this stuff. And therefore, I need you to intervene. And
I think the 80s of today are like the 70s of 20 years ago.
They're in a lot better shape.
And people are living much longer lives.
Got better drugs.
I've got patients into their 90s, late 80s, who are independent, living on their own, driving themselves everywhere, cooking for themselves, cleaning themselves, and they want to enjoy their quality of their life, the last years of their life.
We're seeing more and more patients who are coming in their late 60s, 70s, and 80s with severe degenerative problems, and they're very challenging problems. They're the hardest types of cases to do because you got these essentially the buildup of arthritis, compressing a thin membrane for years and years and years, and you're removing that material that's been there for a long time. That's essentially causing that membrane to be very thin. So to remove that membrane, that material from the membrane, you just got to be really, really careful. And every move you make, you got to just make sure what you're doing is safe.
Yeah, safety is key. And the fact that we have the experience allows us to do it in a quick fashion. And I think there's something to being a surgeon who's thorough.
Expeditious.
But also being expeditious, being quick about it. Not taking 12 hours to do what should take 3 or 4 hours.
And I think that's what allows us to have a very low infection rate.
Absolutely. The longer you're in the operating room, the more people are coming in and out of the room, the more time the door is being opened.
More time it takes for bacteria to basically proliferate.
Correct. And that leads to a higher infection rate. So that's why the skill of the surgeon is really critical. Not all surgeons are the same. There's different skill levels, different experience levels, different levels of facility with the procedure, and experience. It ultimately comes down to experience. You want somebody who's at the top of their game, who knows what they're doing, who can do it safely, and can get you on and out, can get you out of that operating room as quickly as possible and as safely as possible.
That's our goal.
Yeah, and it's we kind of take it for granted because we do it every day, but the patients need to know that as well. You have to have confidence in your surgeon, and don't worry, we do what we would do for our own family. That's basically our motto. You do what you would do for your own family members.
What do you say? What did during the operation? It's not all just business in terms of that. We often talk about things while we're operating because it makes the case, I think, go even better.
Well, not only do we talk about things, but we listen to relaxing music.
We listen to a lot of music.
Dr. Sonstein's a big fan of Pink Floyd.
I think basically the music
the Dogs
synchronizes well with my
animals,
with my hands, and during the surgery, I just find that it helps me operate as best as possible when I'm listening to that type of music. That actually, I think, helps me focus.
I think it puts you in a zone.
It puts me in my zone, which I really love to be in. And we tell stories about our training, and you like to tell a lot of stories, particularly about Dr. O'Leary, who's a world famous spine surgeon that you trained under. You really trained under some unbelievable people. I mean,
there's Dr. Bawachi from Ghana,
who was probably the greatest scoliosis surgeon at the time, and then you had Dr. Kamisa, who's like one of the great spine surgeons in the city, and you got Dr. O'Leary. And you tell, and Dr. O'Leary used to operate on a lot of famous people, and you often asked him, like, how do you mentally deal with that? You're operating on these really famous people. What did he used to say?
So he would get patients from royalty to professional athletes, and I always wanted to know, like, do you get nervous when you operate on people like this? And he said, no. What I do is basically every case is the same. It doesn't matter if they're the future Prince of Greece or they're some Joe off the street. It doesn't matter. I will do the exact same operation, and he's able to separate himself from the stress of being nervous about really that operation.
Very, very key.
You don't want to be nervous. You don't want to be second guessed. You don't want to be thinking, am I doing the right thing? I'm more nervous because I'm operating on a VIP. In my estimation, every patient's a VIP. They all get the same exact treatment. Okay, so and that's really the words to go by. So you don't get nervous ever when you're operating.
That's right.
Because you're confident in the operation. I do it the exact same way, whether you're the CEO of a Fortune 500 company or you're a garbage man. It doesn't matter to me. It doesn't matter what kind of work you do. You are a VIP in that operating room, and we will do our best to make sure you get a great outcome.
That's right.
We want you to get better. We want you to succeed and go back to work and go back to living your life the best you possibly can. Pain-free, hopefully improvement of your numbness and weakness. We don't guarantee improvement of numbness and weakness.
Well, you can never guarantee when it comes to the nerves. Nerves are mysterious things to a certain degree. It's like back pain. People have a condition that's similar to what we were just discussing, lumbar stenosis, where they get severe compression of their nerve sac down below. The spinal cord actually is not down there in the lumbar.
The spinal canal and the spinal cord ends around L1, L2. So patients are always afraid
of being paralyzed.
You're gonna hurt my spinal cord when you do a lumbar laminectomy, and you have to explain to them, no, we're well below the spinal cord. That's never going to happen. The
spinal cord ends at L1, and where all the action usually is around L3-4, L4-5, L5-S1.
Yeah.
So patients should not fear that outcome. Being paralyzed, even working around the spinal cord, we just don't have that outcome. That's like winning the lottery, like the Mega Millions, ever getting a nerve injury or worsening neurological deficit. Sometimes people can get a nerve palsy, or they can get a temporary problem, or they can actually have a delayed improvement. That can happen with nerves as well. But the back pain issue in people with spinal stenosis is more tricky. Back pain can be caused by a lot of different things, not just the spine, but it's the thing that disables the patients is the terrible nerve pain down their legs. That's something that I think that if patients have that relieved, they're much happier and they can manage much better.
Yeah, back pain's a very complicated problem. That can be caused by degeneration, but it can also be caused by stenosis.
That's right.
I'm not. Even not just stenosis, but also what we used to call supratentorial, things that are in your mind. There are some doctors who believe
there's a mental aspect.
Stress can be a contributor to pain, especially back pain, and it's still real pain. But that's where the experience of the spinal surgeon comes in to realize this is something that can be helped with an operation, or something that really is not going to help the patient. because that back pain is not being caused by their pathology that we see on the imaging studies, the MRI and the CAT scan.
I think we've had mixed results with patients with just present with back pain and spinal stenosis. Even if their spinal stenosis is more of a classic type of pain where people tend, with spinal stenosis in the lower spine, they get better when they flex forward. When they sit, when they walk, they tend to extend their spine and close down the canal.
Yes.
That's when they elicit the pain. So patients who have no leg pain or no leg symptoms at all, even not even having buttock pain, just back pain that gets better when they sit, those people I'm a little more leery about recommending surgery.
Because their back pain may be more arthritic in nature.
Right.
And the arthritis may not go away because usually you don't have arthritis just at one level.
It's multiple levels.
It's really
it's judgment call in that situation.
Yeah, absolutely.
I think most of the patients we select for surgery for lumbar spinal stenosis are patients who have some sort of pain going down in their legs or their buttocks that is sort of related to positioning.
How about patients who just have isolated neck pain?
Well, that's a real difficult problem.
And you have a degenerated disc in their neck, but no significant compression.
Do you
offer them surgery?
We generally don't in those situations.
Sometimes we do.
Well,
if they're refractory to everything else,
you like them to have some sort of correlative pain or numbness down their arms, but if they've tried everything and they do have an obvious problem or deformity or something and they have the neck pain, then it's not unreasonable to recommend surgery.
To do a fusion on those. Or maybe that's where a disc replacement would come in. If it's just isolated a black disc in the cervical spine without much compression, then you can do that. Because, a lot of the pain of arthritis in the neck may be coming from the posterior elements.
Well, that's the thing.
That's why I'm not sure that the disc replacement is going to be the answer.
Those joints are also pain generators.
Yeah, so they still might have neck pain because they're having F.A.C.S arthritis in the back of the neck, and you're not addressing that with the disc replacement.
Sometimes those patients will send for a procedure for a pain management specialist to actually burn the pain fibers that supply those joints. It's called a rhizotomy.
Rhizotomy.
They don't always work, though.
Yeah, I always worried about burning nerve. I don't like that idea of burning nerves.
Well, they do use ultrasound. They don't use fire.
They don't use fire.
No.
There's also radiofrequency ablation that some pain specialists are using.
Radiofrequency is a way of selectively
blocking the vertebral nerve.
Those nerves that actually supply the joints.
They do that on the lower back more often than the neck, but I've seen it done on the neck as well.
I've seen it done in the neck. I've seen them do all types of things to get rid of pain, but sometimes the pain does not go away and they come back to us.
Well, and that's where the expertise comes in.
That's where we have to make a decision.
And then oftentimes the good thing about having you as a partner is that if I'm not sure, I can always send the patient to you. Maybe you can figure it out. We've had some interesting cases where we've both looked at the patient and tried to figure out where the pain generator is from or what's causing their symptoms. And it's a collaborative effort a lot of the time.
Two heads are better than one when it comes to spine problems.
And four eyes are better than two in the operating room.
That's correct.
So that's what's the key to our success.
So we're going to continue on with working together as long as I guess we can continue to operate.
As long as they keep paying us, we'll keep working together.
That sometimes is not always
the
battle.
Case.
It's a battle. Everything's a battle.
Everything's a battle. Life is a battle.
Spine surgery is like war, like you said. It's a war. It's basically a war. Eliminating the offending problem.
Right, and that's why you want the best imaging possible beforehand. So you have a map of where to go.
A lot of times the imaging
you want the best team possible too. It's not just us.
We have great people in the operating room.
We have nurses.
That's right.
We have scrub techs. We have anesthesiologists. We have a plastic surgeon that we work with consistently. And all those are members of the team that make things go smoothly.
We like to use the same people every time. We like to keep it
consistent,
boring as possible in a way with the room. We like to keep it the same routine every time.
Boring is good in the operating room.
Boring is good.
Excitement is never fun.
We don't like excitement. We like everything to go routinely.
We want things to go smoothly and quietly. We like the room nice and cool.
Oh yes, that's always an issue. Getting the room as cool as possible.
So usually as a patient, when you come into the room, you're going to be like, "Oh my God, it's so freaking cold in here. How do you guys operate?" What you don't understand is that
we're under lights.
We have very focused lights that we have over the operative site, plus we're wearing headlights, plus we're wearing gowns. Sometimes we're doing
wearing lead,
lumbar fusions. We use lead to protect ourselves during the fluoroscopy portion of the case when we take intraoperative X-rays. So it gets very, very hot in there, and you don't want your doctor sweating on the wound. So we like it very, very cold in there.
Yeah, that's the way to be, as cool as possible. And
some people actually think by keeping it cooler, you have less chance of infection too.
You have less chance of infection, and also I think it's neuroprotective.
Yeah, that's true. That's definitely true.
So.
But it's been over 20 years, and hopefully we'll have another 20 years to go.
20 years?
Yeah, maybe not 20 years.
I don't know. Maybe 10
15?
Years.
15.
All right.
How old is your youngest?
My youngest is 13. I still have to worry about her going.
You got to worry about college and graduate school. So
I still got paid.
You got to work at least another 11 years.
All right. Well,
right.
Okay. As long as you're willing.
We'll take that. I'll be there.
All right, Spine.
I have no other hobbies.
I'm trying to develop something other than neurosurgery these days, but
traveling
would be nice to do sometime.
Yeah, traveling would be nice.
You like to travel.
Traveling keeps you young.
It's work to travel. It's a lot of work.
Some trips are more work than others.
Yeah.
I think Alaska's a tough trip because you got to pack for all different kinds of weather.
Alaska was a lot of work getting there, but it was worth it, though. That was a beautiful, beautiful, beautiful place.
And some trips are just more like you go on a cruise to the Caribbean and it's just relaxation. Yeah. So you need a little bit of both.
But when you do spine surgery, it takes a lot out of you emotionally and physically. It's like a basketball game.
It is.
And I go home. I'm like I can't do anything. I'm like I literally veg out on my chair, and
you've got to be prepared.
The other night I watched Pretty Woman to just make me to cheer me up. After. So you need that kind of stuff when you work so hard in the operating room and focus so much.
Yeah, you got it. It's a several hours of intense focus.
That's right.
And intense concentration, and you're working with your hands. You're standing the whole time, so it's a physically demanding job. And when you expose the lower back, especially, my glove size actually went up half a size when I was a fellow from retracting the spinal tissue so vigorously with the muscles. So my hands hypertrophied a little bit.
Oh yeah, absolutely. People actually complain about my handshake.
You got a strong grip.
I got a very, very strong grip after squeezing.
No dead fish for you.
I squeeze this instrument and to remove bones. Sometimes people's bones are so hard. Actually, it's a welcome situation when we have to operate on an older.
They're osteoporotic. It's easier to remove the bone.
The best situation because it's so much easier.
Well, we have some new technology, some tricks that we use to soften the bone during the operation.
We have lots of interesting tools. We have first of all, sometimes patients who have very, very hard bone, we have to drill the bone down to a fine shell. We also have an ultrasonic tool that actually melts the bone away. Misonics, which is a great tool to use, particularly in patients who have basically have had prior surgery or what we call revision spine surgery, where you have to develop a starting point essentially between the bone and where the scar really begins. It's sometimes very difficult to develop that plane. So the actual misonics, by melting the bone away and sparing the soft tissue, really gives us an opportunity to develop that starting point. And once you get the starting point, things go very well.
I find the misonics to be very helpful in revision cases, especially.
That's right.
Where it's sometimes hard to find that edge of that bone to remove.
Getting that edge is key.
And that's the key. Once you get that edge, it becomes a little bit easier. But it's getting that starting point. We work very hard to
get that edge in those revision cases.
Yeah, and there's some tricks that we use. And again, I keep coming back to this. It all comes back to experience. So we're willing to use new technology because those devices didn't really exist when we were fellows and we were residents. There was no misonics.
There was very little stuff that's...
And there's another device that we use that helps, which is also ultrasound-based.
The Aquamantis.
The Aquamantis, which is really an excellent device for preventing bleeding during operations.
It looks like a big prong that basically floods the field with water, and by ultrasonic
it heats up the tissue.
It basically shrinks the blood vessels over a wide swath of tissue, so you can control bleeding, and particularly if people have had prior surgery with a lot of scoring, which is very vascularized.
Yeah, so we generally use that those devices in the posterior approaches to the neck and the lower back. Not so much for the
Anterior, you
anterior.
don't need it as much because you're not
Not as
getting
bloody.
that kind of bleeding. No.
Not as bloody.
We actually recently have been using that great tool called the ligature.
Oh, I love the ligature.
That's good for anterior because in the anterior, you have big veins sometimes that are in your way of getting down to where you need to go. So by using that device, it sort of divides and coagulates at the same time the vein that can be safely taken.
Right. So the ligature looks like an electric scissor.
Yeah, it looks
basically
like a big scissor.
And so you basically take the scissor and you clamp it over a tissue, and it will. You hear a beep for a couple beeps, and it will lyse that tissue and cook it.
It lets you know when it's ready.
And then you open up your tissue and it's been cut, but it's bloodless.
It's bloodless, so it really allows.
So it really minimizes bleeding. Like I would say that in an anterior cervical situation, for a one-level case, we lose about 10 cc's of blood
at most,
which is minimal.
Right.
You probably lose more blood when you do the blood tests for pre-surgical testing than you actually do during the operation. So it's really a bloodless operation. We've
had all types of I'm going to say patients with very different types of body habitus.
Yeah, and that can be a challenge, especially somebody who's extremely overweight.
We had obese. A patient recently that was near 400 pounds.
Yeah, that was fun.
I was a little bit hesitant. I'm like, are we really going to be able to get down there?
I knew that we could do it.
Why were we able to do it? Why do you think we were able to accomplish it? It was actually very easy, actually.
Because most of his weight was in his abdomen and the lower body. His neck
was soft.
It wasn't that difficult to get down to his neck. We had to make a little bit of a larger incision, but we were able to do it without difficulty and get down to that level where the herniated disc was.
Once you get
really surprisingly easy.
It was actually surprisingly easy. Once you get through the fat, you really can actually realize that everybody's the same.
Pretty much.
So once you get through,
it doesn't. Yeah, absolutely. It doesn't matter if you're heavy or skinny. Once you get down, the disc is the disc.
So we take care of all types, and we're able to accomplish some pretty amazing things in people that are, I think, sometimes being refused surgery.
As a follow-up, that particular patient who was the 400-pounder, the hardest problem in that case was getting the imaging to make sure we were at the right level. Because
that was the hardest challenge.
You had to pull the shoulders down to be able to see if we were at the correct level. I believe he had a 5/6 disc.
You don't realize how much we have to work to really just to identify and to make sure that we are absolutely operating at the right level.
And we are meticulous about that.
We will never, ever operate at the wrong level.
Yeah, that would be bad.
So anyway, Spine Bro, this was fun just getting together and talking.
Yeah, it was very enjoyable. I hope we can do it again sometime.
Let's do it again sometime.
That was good. Hopefully people will like it.
All right.
All right.